And welcome to Prof. Marguerite Schneider and to Roxanne Jacobs, who are both here from the Centre for Public Mental Health, the Alan J Flisher Centre for Public Mental Health, where they will present to us on making dementia visible, so a public health, social care and human rights issue. And by way of introduction, to just say that Prof. Schneider is a retired associate professor from the Centre for Public Mental Health and who has graciously given us this presentation today and taking out of her valuable retirement time to be here to present on this incredibly important work. Prof. Schneider's early career was in speech-language pathology and audiology before moving into the broader social sciences, where she began focusing on disability studies and on mental health. And she's led this South African Word on the Stride project, which will be the main focus of the presentation today. And this project is specifically aimed at strengthening the responses to dementia in developing protection and in mental health and dementia more broadly. And she's currently an active member of the Washington Group on Disabilities and the co-chair of the Mental Health Measures Working Group. And then our second speaker, who is Roxanne, is a research officer at the Centre for Public Mental Health. And she's led work with multidisciplinary teams on various public mental health issues. And she joined the Stride project in 2018, where she's been coordinating various research activities and several work packages, which I'm sure she'll tell us more about in the presentation. And she's also currently in her final year of her PhD, and that's entitled Elder Abuse in South Africa, Measurement, Prevalence and Risk. And so we look forward to welcoming Roxanne back then when she will present on her PhD findings. But that is enough from me. I'd very much like to introduce then Prof. Schneider, who will begin the presentation today. So if I could ask if you have questions, you can continue to populate the chat in the meantime, but we will also have a dedicated slot at the end where people can ask questions to our presenters. So that's it from me. Thanks very much.
Thanks, Bronwyn, and for asking us. And just to add that I was retired by UCT, so I'm not sure that I count myself as retired quite yet. So what we're going to talk to you today is about a 4-year project. It's a multi-country study that's headed by the London School of Economics and Political Science, more specifically Professor Martin Knapp. And the 7 countries that have taken part are, and I always have to get my regions right, it's Jamaica, Mexico, Brazil, Kenya, South Africa, India, and Indonesia. So 7 middle-income countries. So we're going to focus entirely on the South African part of the work. So to start off, I just wanted to present this case study, which some of you living in Cape Town will have heard about Gus, who has had Alzheimer's disease and was living in a private retirement facility or long-term care facility in Noordhoek area, and he walked out of the place and was eventually found after a lot of searching. I think it was about 5 to 6 days. He was found sitting on a bench on Chapman's Peak Drive overlooking the sea, which apparently was his favorite spot. So why did I want to present this? Well, I think to give a face to dementia, first of all, and this is not an isolated type of case study, but I think more importantly to highlight firstly that Gus had a diagnosis, and secondly, he had access to private long-term care where either he or his family had the finances to support him being in that long-term care facility. And this is very much not the common picture in South Africa, and in fact in most of the 7 countries that took part in the Stride project. So I thought that was quite a useful way to start. And I think his story is very poignant, and to what extent, you do wonder to what extent he had sufficient know-how to actually go and place himself there, knowing it was his favorite spot. So there's lots of very moving things about the story. So we're going to do a brief overview about on the STRIDE methodology, and I'll present that. And then Roxanne will move on to present some key highlights of the findings in South Africa and some recommendations for moving on, and we can end with some discussions. So what was STRIDE all about? So the overall aims of the STRIDE project across all 7, why have I lost them on here? In all 7 countries was to contribute to improving dementia care, treatment and support systems so that people living with dementia are able to live well, and that family and other carers do not shoulder excessive costs, risk impoverishment or compromise their own health. So it's really around the care and support systems rather than the medical diagnosis or medical interventions. That's not going to be the focus at all of our talk or of what STRIDE was. There were 10 work packages in STRIDE, and the ones highlighted with a red outline are all the ones that South Africa took part in. The 3 main data collection packages, which were work package 3, 4, and 5, were only done by a few countries in each. So each country only did one of those work packages, except for work package 3, where all countries did a very basic piece of work on stigma, which we'll also include in our findings that we report back on. So we started with the theory of change workshop in each country. There was a whole lot of research training for early career researchers that were employed full-time on the projects. Work package 3 was looking at stigma. And as I said, each country did a small piece of work on that. Work package 4 was a very detailed, grounded theory, qualitative piece of work looking at the experiences of carers. And largely unpaid, providing unpaid care. And work package 5, which was the South African one, was looking at trying to establish prevalence of dementia, of probable dementia, and also looking at care pathways and access to healthcare and support systems. Work package 6 was a systematic review on dementia evidence, what works, what doesn't work in middle income countries, and that will be available as a searchable tool on the STRIDE website. We also did a situational analysis in all the countries, and also developed typical care pathways, and all that hopefully feeding into eventually, although we didn't get to that, a cost modelling of human resources and financial resources required. Work package 8 was done by the NGO in each country, which was it was always a member of the Alzheimer's Disease International Organization, who were a partner on it. So we worked very closely with Alzheimer's South Africa. And then work package 9 was management, and work package 10 was about knowledge exchange and dissemination. So why do we want to understand about dementia? And firstly, it allows to improve services that then helps us improve and maximize the ability of people living with dementia to live a meaningful and dignified life, and also to develop support and support services and resources for families and carers, so that they do manage to also live a good life and not be completely burdened by the care. So how did we develop this understanding? Well, firstly, we did a desk review, which started off the situational analysis, and out of the situational analysis, we did a SWOT analysis, the strengths, weaknesses, opportunities and threats analysis, based on the desk review, and we'll present a few key highlights from that. We added some stakeholder interviews to get the stakeholder perspectives, policymakers, people living with dementia, carers, healthcare, the departments of health, social development, a wide range of people. And then looking at filling the evidence gaps that were apparent in the 7 countries. So in South Africa, the prevalence rate, the need for prevalence data was was paramount, which is one of the reasons why we did work package 5. But also trying to understand stigma in all the countries as well, to also develop care pathways, understand what happens when somebody shows signs of memory loss or whatever, what happens in their attempts to try and get care and a diagnosis. And also trying to collect information on the costs of health and social care and support. So in the situational analysis, it was a very detailed piece of work that gave us quite a good picture. You can see we covered a wide range of topic areas, and this document is available on the Stride website. It's a searchable tool where you can go to any country and any topic and get the information, well, across all 7 Stride countries, and the website is there. And the information also fed into the WHO's Global Dementia Observatory, which is another searchable tool to get information on different countries, much more global. Yeah, so those were the key parts of it, but it covered a wide range from health systems, long-term care systems, policy context, research, whole social protection, a whole range of things. Then what we also did as work package 7 was to develop a series of vignettes that describe typical cases of people with dementia. And as for Stride as a whole, we developed 5 vignettes that were common across all 7 countries. And then within each country, we then refined those, adapted them, using the information from in South Africa, our stigma work, our work package, our survey work, and our situational analysis to adapt those vignettes to make them relevant for South Africa. We also developed 3 additional vignettes to tap into different areas, and all 7 countries developed additional vignettes. We also developed detailed narratives about the care pathways that those people experienced from that, and Roxanne brought beautiful diagrams of the care pathways, which she'll present a bit later. And we also did quite a lot of consultation within South Africa with our National Advisory Group, with Alzheimer's South Africa, Dementia SA, a whole range of stakeholders and people living with dementia. We had one couple, he's a carer and she's got dementia, and another person who she joined us right from the beginning and was on our National Advisory Group, and actually commented at some point about how much she appreciated being part of the project, and she felt that it gave her a sense of worth and contribution, and she really did contribute useful things to the project. For the stigma work, we basically, this was a very small piece of work. We did it in the Durban, Pietermaritzburg area and in the Bloemfontein and surrounding area. We interviewed people living with dementia and their carers. We did about 6 interviews in each site. We also targeted primary healthcare workers in a clinic in each site, so it was very limited. And in the Free State, we interviewed individual primary healthcare workers because it was difficult to get a focus group. In the KZN, we managed to get a focus group with primary healthcare workers at a specific clinic. And then we also tried to access the general public, which was very difficult when you're only doing 2 focus groups. So we did a faith-based organization in Free State, and it was a group of in fact, all women, middle-class white women who run a tennis club in Pietermaritzburg, I think it was. Yeah.
What is ASA?
Sorry?
What is ASA?
ASA, Alzheimer's South Africa, sorry, who were the partners on the project. Then for the survey project, we basically used the 1066 short algorithm. The 1066 is an older person's dementia study run by Martin Prince at the King's College London, and it's a whole assessment battery. So there's a longer version and a short version, and that based on this algorithm, you can say whether somebody has probable dementia. It's not a diagnosis, but and there's been a lot of validation of this in a number of countries, both high, middle and low income countries, and is recognized as quite a useful assessment battery. So we combined that together with some other tools, and we targeted older adults, 65 years and older, and the languages were English, Afrikaans, Xhosa, and Sepedi. And I'll show you all the topics that we did cover. And the informants in each household, we also interviewed an informant who had to be 18 years older, living with a person or knowing the person very well. Not necessarily being a carer, because not all the older adults needed carers. And again, the same languages, and I'll show you the things. So the data collection happened in Limpopo, a place called Dikgale, which is just outside Mankweng, which is just outside Polokwane. It's by Limpopo University, and we partnered with them on that. And we targeted 14 villages there. And
Hi, sorry, I don't know if anyone can hear me. We haven't been able to hear Margie for a while, the online audience. I think the presenter computer is muted.
We still can't hear.
Is that better?
Yes, thank you.
Okay.
Okay, thank you. So, okay, so some of our results. So like Margie said, we worked on a SWOT analysis, which is basically using the in-depth situational analysis, the desk review report that Margie was talking about. And we looked at what are the strengths, weaknesses, opportunities, and threats in particular areas like the healthcare system, the long-term care system, and the policy environment in South Africa. So just to give you some context in terms of what we found, in terms of describing what the dementia care context looks like in South Africa, our healthcare system, as we know, it's characterized by inequalities in terms of access to healthcare. There's an urban bias, and there's inequality in terms of resources allocated across provinces as well. The public healthcare sector is overburdened and providing support to about 84% of the population, whereas the private sector is better resourced but providing care for the minority of those who can afford it or can afford out-of-pocket payments. We also see a overrepresentation of physicians and nurses within the private healthcare sector, catering for the minority of South Africans who can afford and access those services. And whether it's private or public sector services, we found that there's a need for dementia awareness because there's this common belief that dementia is a normal part of aging. In the long-term care sector, there are residential care facilities available, but these are often in the private sector and quite expensive and inaccessible. Also, there are a few in the public sector, but they are very limited and they're not dementia specific. And they're normally targeted at frail care, and not everyone who has dementia is frail or need frail care. We do have community-based services, and for this, our state really relies on NGOs and faith-based organizations to provide these services. The majority of care, however, happens at home and is usually rests on the unpaid care provided by usually a family member within the household. In our policy environment, we do not have a dementia policy or health strategy. We do have strong policy support for universal health coverage, but the implementation of the national health insurance is quite slow. And of course, all of these factors, we know we have a fragmented health system. These have all been more exacerbated by existing vulnerabilities within the system, and the pandemic, of course, made that worse. So just to give an overview of what our SWOT analysis showed within the health system, on the positive side, we do have free access to primary health care in the public sector. We do know that this access is unfortunately unequal, and it's an overburdened system. Like I said, 84% of the population relies on this particular services. And we have strong policy support for an integrated care model that that realizes and responds to decentralizing primary care at the household or at the community level, at least. However, there are serious HR shortages in terms of providing these services, and there's this general lack of awareness and understanding of dementia amongst community health workers or healthcare workers in general. In terms of opportunities, with the national health insurance drive, there is an opportunity to integrate some of our dementia needs and SOS provision needs within this particular drive. And that is to support purchasing more specialized services from the private sector. However, there's a tendency to focus on more treatable conditions like HIV/AIDS, TB, reproductive health, and child health issues, with also a slow progression of the NHI, as I mentioned. The community health workers is quite an important resource at community level, and with ongoing training, there's an opportunity to integrate some of that dementia focus within their training. The challenge there, or the threat there, is because there's a shortage in staff and human and capital and financial resources, they are already overburdened. So there's so much to go around, but there's not enough people to man the mandate of what we need in terms of responding to dementia services. We have limited community awareness as well and knowledge of dementia. And of course, stigma. Stigma plays a massive role in preventing help-seeking behavior, but we'll unpack it a bit more later. In terms of the long-term care system, we have a well-established social protection and security system in place. We have very strong responses from our NGO sector. They offer community-based dementia-specific services. And we do have public residential facilities, so that's positive. These things exist. However, often our social protection, like for example, the old age pensions, entire families rely on that income because it's often the sustainable income in the household, and that often makes them vulnerable to exploitation. The NGO services is often urban-based, so you can't really get to where all the need is, and it's also at a cost to the family, understandably, but they are severely underfunded, especially now post-pandemic. We mentioned the few residential care facilities that is run by the state, but they are less than 8 nationally, and they are overburdened. They cannot meet the demand, and they really just reserved for the destitute and those who need frail care, which is not dementia specific. Yeah. In terms of opportunities, we spoke about the NHI drive, and another positive opportunity is that the departments they acknowledge that the need isn't to invest in more institutionalization, but is to focus on community-based care. So there's an opportunity there to mobilize support for dementia services. However, there's a lack of trained workforce to respond to these needs, a lack of specialized dementia care and training opportunities within the healthcare sector itself as well. And the NGO who we rely on to provide these community-based services, they are based on a failing funding model. There is constantly budget cuts. Departments know they are not adequately funding these NGOs, and their hands are tied. So yeah, it's quite a difficult situation, which means that families and people living with dementia largely live unsupported at home, trying to do their best. And this, of course, increases risk for elder abuse and neglect. In terms of our political system, we have very good policies. We have lots of those, and they are talking about, they're basically embedded in these philosophies of active aging or aging in place, which is fantastic because it's about making sure older people participate in the communities, they participate in making decisions of anything that affects them, and that they live and interact, participate in the community for as long as possible. So that's great. There's a lot of private and public support for the mental health policy framework, and we spoke about the NHI and we spoke about the mental health policy framework, but there's a shadow side to the effect of emphasizing care within the home environment, is that there's a gendered burden that emerges, where the care, the primary responsibility falls usually on a female family member that often, in our context, has to actually quit a job to provide full-time care for someone living with dementia. And the policies, they embrace these philosophies, which is quite noble, but they're dementia invisible. So people living with dementia and their families are not getting basically the response that is required. And there's no specific objectives that speaks to dementia. And most importantly, we can have fantastic policies, but if there's no budget attached, you can't implement anything. So those are some of the main threats and weaknesses within the system. Okay. Care pathways. So Margie spoke about, we started fleshing out what are the different scenarios that people access help with. So in South Africa, we're culturally diverse. There are many routes that people follow in terms of seeking help. So we had about 8 different care scenarios that was developed throughout this project, and in consultation with people living with dementia, their families and stakeholders. So what we tried to do is to summarize all that 8 into what looks like a typical care pathway for South Africa. So I'm just gonna go this quick. As you can see on the screen, we're talking about pre-identification, that's phase, the identification process, post-identification, response and ongoing support, post-diagnostic support, if you want to call it that, and end-of-life care. So in the pre-identification phase, a person with symptoms or a person living with dementia, of course, face all these barriers, and they range from the beliefs that it's a normal part of aging, family stress, self-isolation, fear of rejection, anxiety, stigma is quite a big one. feelings of loneliness and isolation. But the family is quite a strong source of support, which is also not just looking at things from a deficit model, but also it's a strength that can help the individual overcome some of these barriers. So one of the typical routes would be the traditional route, where people often, their first port of call for help is not normally a doctor. Sometimes it's reaching out to a faith-based organization, a spiritual healer or traditional healer. And that involves identification of the process, of the problem, and recognition of the experience within that particular context. It's followed by a response and then support in the home environment or in the community. The medical route, people often access help at a primary healthcare clinic or a private GP. It gets referred for diagnosis. And this is where we see there's a cyclical process in actually getting a diagnosis. This diagnosis is not a guarantee, and it can take years sometimes to obtain that diagnosis. So it's about differential diagnosis, often misdiagnosis, often it's misconceived as depression or anxiety, or they come out of the process with no diagnosis at all and completely unsupported. A lot of the people that we spoke to, some participants were talking about they'll receive a diagnosis, but no information about the disease or what to expect, no treatment, no intervention. And that's going through the medical system itself. Sometimes they are linked to palliative care when needed. Sometimes they're linked to care homes or long-term care, formal long-term care facilities. But most of the time they end up at home. An important structure within the system is the NGOs structure. A lot of people sometimes access it directly and then get referred to a healthcare system or to a faith-based organization for support. But essentially, the NGOs provide care, education, and training. They really provide that support to the family, home-based services at the community level, at the household level, and they provide support in terms of support groups for carers and people living with dementia. And they link them to services either in the healthcare sector or in the formal care sector, or the faith-based organization. So there's a lot of arrows going around. As you can see, it's quite complex, but what they all have in common is that they all end up, most likely in South Africa, the typical care pathway and support structure would be the family, would be the home. Often a female family member that provides the care. So after doing this exercise and extensive consultations and trying to summarize these different scenarios into this, we had to look at what can we do to strengthen and build on what we already have. Because resources, of course, is quite constrained in South Africa. So we tried to streamline the process and started identifying where we can build on existing systems so that we can provide a strengthened and a more dementia-friendly care pathway in South Africa. So the numbers indicate, I'll just give some more context to those. In the pre-identification phase, we were talking about anti-stigma and community awareness and education, which is quite important. And then training within the spiritual realm, the traditional healers, faith-based organizations, because these are fundamental support systems for communities. So it's about training on the identification and what kind of responses are appropriate within that context, referring to community-based services, faith-based organizations, medical facilities, whatever is needed. And the same goes for training on dementia identification within the healthcare system. So that these two systems are often polarized, but if they are brought together and there's a bridge made between these two communities, in the service of supporting people living with dementia, we need to understand what that looks like. And we need to understand how we can strengthen that so that families don't fall through the cracks. So within the healthcare system, it's about early detection, differential diagnosis, strengthening treatment, and having that person-centered medical care, but also a family-centered care support system. Because in South Africa, one of the traditional healers that we spoke to in this consultation was saying the traditional route appeals to families because the whole family gets consulted. Whereas in the medical system, we only look at individuals. And the health decisions are often made within families, so we need to respond to that need. And healthcare system needs to be sensitized to those kind of realities in South Africa. And then number 4, develop career pathways for paid community workers. At the moment, there are so much discrepancies between how much community care workers from Department of Social Development is earning and what their roles and responsibilities are versus that from community health workers in the Department of Health. And they provide a fundamental service at the household level that is needed for these particular services. And yeah, we need to formalize those structures. How? Okay. And then number 5, home-based care support for individual and family till end of life, where this is required. And this is about referring to community-based services for care and support, faith-based organizations, etc., for long-term care services. And then number 6, dementia-specific, person-centered long-term care and palliative care, where appropriate. Okay. That was a mouthful. Okay, our next bit of work is on the stigma and dementia. So this paper just came out a couple of months ago, and we, like Margaret said, we interviewed people living with dementia, their carers, and we interviewed the general public. We interviewed healthcare workers in 2 clinics across 2 provinces, which is in KZN and the Free State. And there was a lot of themes that came out, but we grouped them in terms, what we saw is a lot of examples of internalized stigma, that fear, that shame and self-withdrawal. Public stigma, which is about stereotypical attitudes and prejudice and discrimination towards the person living with dementia and the family. And then structural stigma, and we'll describe the dementia plan system now. So we'll look at these individually. Okay. Internal stigma. Here we found people talking about hiding or delaying or not disclosing their diagnosis. They expressed feelings of shame, fear of losing the right to control their own possessions and their own money. When they decided not to disclose, or when they decided to disclose, it was normally to immediate family and only those individuals who they thought really needed to know. Though others decided they will not disclose as far as possible. And this is because of fear of community being, other members in the community seeing that they are vulnerable in some sense and then taking advantage. Others actively went out to mask their vulnerability. They would keep up appearances, make them seem very active in communities, deliberate public displays. For example, one grandmother was talking about how dementia is something that only happens to the granny that sits down. But if I go outside and I sweep my yard and I'm busy, everyone sees me busy, no one will suspect. And I'm safe that way. Others spoke about family resentment and how the diagnosis, accepting that diagnosis was a process itself, where there's one lady in particular, her husband was diagnosed, but her children refused to accept the diagnosis and they blamed her. And it caused a lot of conflict in the family and that family resentment where they were blaming her for overreacting. So or she's imagining it. And she had to deal with that. The best way for her was to rather just withdraw, stay away from family. And it's a lonely space. Public stigma. There's a lot of talk about dehumanization of the person living with dementia. They were described as being an empty shell. What's the point of visiting someone because he or she won't remember me being there? So, yeah. Dehumanizing the person. And then avoidance. People stop visiting. And others who spoke openly about their experiences, they felt that people would draw back, they would withdraw, or they would shun away from them when they started talking about them. People didn't want to hear about their negative experiences. And then fear of harmful beliefs. The fear of reactions to common dementia symptoms. People didn't understand what they were seeing, especially when the older person was undressing or acting confused or talking about people that lived long ago. So people are not comfortable with those kind of reactions. And then what some carers actually spoke about is hiding their family member as a result, and restricting their movements, because we don't want confrontation from the community. We fear being labeled and whatever reactions. So let's just keep mom inside. Structural stigma. Amongst the healthcare workers that we spoke to, we could see that there's definitely this norm of ignoring dementia or dismissing it. It's a normal part of aging. Grannies are supposed to react that way or behave that way, or nothing can be done. But this idea of nothing can be done is like a two-edged sword. There's this belief on the one hand that yes, you can't do anything to treat or so. And on the other side, it's about, look, there's no services to refer the person to. So what's the point of giving a diagnosis without support? So let's rather not label. Let's just send granny on. So it's a bit of that. No training, no specialized training on dementia. The nurses have some basic training and they are able to identify it, but that is not across the board. It's not standard. And there's a lot of people who do home visitations, for example, the community health workers, they don't receive that kind of training. Carers, especially, were talking about how unprepared the health system is, that they feel like there's no empathy, there's no understanding at hospital level, where staff is phoning them on what to do, but the husband who had dementia is at the hospital within the care of the hospital staff, but the hospital staff don't know how to react or deal with the person. A lot of misinformation that's given. One gentleman was diagnosed, and he remembers he said he was told he got dementia because he's been using computers too long or too much in his life, so that's why. So there's a lot of that going around as well. Misdiagnosis, spoke about that, and then inequalities in treatment prescribed. Yeah. We spoke to two families in the Free State. One in the working class community, one in the middle class community. Both accessed healthcare through a private GP. But the family in the middle class setting went from diagnosis to some kind of treatment within 3 months. The other family in the working class, also accessing private care, took about 3 years. So it really comes down to who it is that you're consulting. So it shows how the healthcare system itself, that discrepancy in training and exposure, makes a big difference. Yeah. And the medical aid as well, we know those who are able to afford it, their tests are not covered. It's mostly out-of-pocket payments. Okay. Long story short, the key message from Work Package 3, which is the stigma work, is that if we look at stigma, we can increase that help-seeking behavior, we can support early diagnosis, and eventually improve quality of life. Work Package 5. Okay, I'll wrap up now. These are pictures from the areas that we visited and did our household survey in. So we did the household survey in Cape Town and the Tigale area in Limpopo. We found, look, the average age of our sample was 74.6. We had more females than males in our group. And as expected, we had lower levels of education in our rural settings than in our urban settings. When we looked at our prevalence for dementia, we found that it was 13.7%, but when we weighted, those figures were by national age, sex, and literacy estimates, that figure decreased to about 11.8%. But this is still a lot higher than the previously estimated 2 to 4% range for the sub-Saharan region. There was a smaller study done in Cape Town in 2017 by Celeste Jager and a team, and they estimated it to be around 11%. So our findings is in line with what was previously found. We found no significant differences between males and females, and we found that age expected trend, the older you get, the more likely it is to develop dementia. This was interesting. We looked at what diagnostic services our sample accessed, and we looked at who had a diagnosis for hypertension, diabetes, heart trouble, and stroke. And out of everyone who we've identified to have dementia, only one person actually accessed a formal diagnosis. Most older adults in the sample did not need care. However, 86% of the older adults with dementia were said to need care, and this is as it was reported by the informants. And almost half of that figure was said to need care much of the time. So basically, what's important here is that we know now that the need for care and support is at community level, especially considering that only one of the individuals actually gets a diagnosis from our study. So yeah, that's where the interventions need to target. Who are our carers? Our carers were mostly an adult child, a spouse or another relative, or a daughter or son-in-law. And we found, if you see the bar chart, we found that care happens in a network. So it's not just one individual, it was mostly 1 to 2. But yeah, our study didn't look at how these networks work, which is nice for future studies, but it's, yeah, we're doing it in a network. And most of them are female, 80% as expected. And a little bit of a PhD study that was added there. We looked at, we screened older adults using the elder abuse screening tool. We looked at financial, emotional, physical, and sexual abuse and neglect. And we also screened carers for risk of abuse using the CASE, which is the caregiver abuse screen. And what we found is that 1 in 10 older adults screened positive for self-reported abuse. And whereas almost half of carers screened positive for risk of abusing, of which 13.5% was high risk. In other words, that to score 4 or more. People with dementia were 4 times more likely to be at risk of abuse from carers compared to those without dementia. Some of our key points. We know that dementia prevalence is high and it increases with age. Diagnostic services for dementia is quite poor when we're comparing it to other diseases like hypertension and stroke. And that we know care falls within the household, often on a female family member. And that the risk for elder abuse is high, with elder abuse being less frequently reported by older adults themselves. Takeaway messages. We know it's a public health concern that needs surveillance and monitoring. We need to start looking at promoting healthy aging and addressing those and targeting the modifiable risk factors. Also, we need an intersectoral response that's coordinated, because it's not just one department's responsibility, it's not just one sector, it cuts across sectors. We need social development, we need Department of Health, we need NGOs, we need the faith-based communities, we need intersectoral response for that. We need to address stigma to encourage help-seeking behavior, strengthen existing healthcare system, improve early detection and diagnosis, and increase quality of life. We think that the self-reported abuse is underreported. It could be because of community screening, the proximity of the abuser being around, or cognitive impairment. That's why it's important that we have tools that screen. Sometimes you have to screen the perpetrator, but to do it in a non-confrontational way so that you can assess risk before the time, intervene before the time. Community-based responses, that's something that came out through all the work packages, where we need to start alleviating that social and financial impact at the household level. And then through that, we need to strengthen home-based responses, care and support services, example, respite care, etc. Overall, there's a need for an integrated and coordinated dementia policy and strategy to bring all these things together. Some photos from. These were the field researchers that helped us collect the data last year. On top is Limpopo, and the bottom is the Cape Town team. Thank you.
Roxanne, thank you very much for the presentation. We don't have much time for questions. In fact, we probably only have time for one. So I don't know if there's anyone in the audience or online, but who's going to, I don't know if we saw a hand up there, but your hand first. So the one and only question we can have.
Thanks. It's very dissimilar. It's very important. I'm wondering about how to promote a more specialized illness like dementia within mental health. And I'm also wondering the second part. This is my actual question, Marguerite, if you quite obvious to answer this. Is dementia can be classified as a disability, a disability grant that would be available to people.
Okay, a quick answer. There's a lot of debate about whether dementia should fall under mental health or should fall under non-communicable diseases or neurological. So there's a lot of debate around that. In South Africa, it happens to be in the mental health policy, although nothing much is done about it. So that is an ongoing debate. We had a lot of contact with the NCD group in the Department of Health nationally. In terms of it being a disability, it fits all the criteria. Being a disability, it's not always recognized. And there's an organization called Dementia Alliance International, which is an organization started by people with dementia. And also the message is about talking about people living with dementia, because people are often told, go home and just prepare all your stuff, or, prepare to die rather than continue living. So that's quite a big, strong reason for using people living with dementia. Creates havoc with your word count when you write papers. And they've written quite a lot of papers and documents around that the Convention on the Rights of Persons with Disabilities applies entirely. It is a health condition which interaction with the environment. So yes, it is a disability. The disability grant won't apply because it stops at 60 anyway and is replaced by the old age grant. So the early onset dementia, and in fact the two women who were involved in our project were both diagnosed before 60. So they would be eligible for a disability grant. I don't know whether the disability grant assessment process would recognize them as being disabled or not. That's a different issue, but theoretically, they are.
My question is linked to the OSA and funds for somebody.
Yes. So the joke that is called the grant in aid it's a joke because it's so little money, but it's there for people who receive a disability grant or an old age grant who need care at home. But it's under 400. How much?
400.
Yeah, I mean it's a ridiculous amount of money.
400.
It's under 1,000. It's just
it's not even minimum wage.
It's actually an insult. It's not even a joke. It's an insult. So yeah, but the idea is to keep people at home but provide the necessary support within the community. So respite care, daycare centres, so people don't have to give up jobs to go and look after their family person.
Well, unfortunately, that's all we have time for. So thank you to everyone online. It's just gone 2:01. Thank you for joining us. This is being recorded. For those of you who may have questions, we can send you the contact details of our speakers who can then also answer your questions via email. So thanks, everyone.
Will the recording have the
Transcript
chat?
and the chat. It might, but if there are questions, I'll take them out for you.
Okay. No problem.
All right. Thanks, everyone. Thank you. Bye.